Good morning, everyone. I'm very happy to be here as a faculty. I think this is the fourth meeting, and I think the fourth time I'm coming to Pune for the conference. So thanks to Unni and his team for having me here this time as well. So as Unni was saying, the important thing today is that we make this interactive, because pretty much all of us have got a lot of experience in managing patients in hospital. We have all worked in hospitals at some stage of our career, and we have seen things going wrong, perhaps more than things going right, because many a times issues with hypoglycemia, more than the hyperglycemia, is what hits us. And that's a huge problem in hospitals, and we will, of course, be discussing all that throughout our this forenoon session. And through all this has developed wonderful guidelines, both internationally as well as locally, and many institutes of repute have got their own protocols, and I think that's fine. You know, there is no rule that says that there has to be uniform guidelines, and I think that is something which we will focus on in the sessions to come. That many times the protocols have to be driven by the physicians and the endocrinologists in those institutes, what they're comfortable with, and what works for them and their team. I think that is an important point. So. What I will try and focus on my next 15 minutes is looking at the inpatient management of hyperglycemia in a non-critical care setting. There are the critical care settings, which Dr. Sanjay Agarwal is going to talk to you after this. There are a number of special situations and case scenarios that we have to deal with. You are aware of those, the steroids and all the rest, you know, the enteral feeding and all that. Perioperative management, all that will be covered in the session as well. So this is the first case that I would like to show you, and in fact I will discuss my talk pretty much around this case. So a very kind of common scenario that we all face, which is a 40-year-old male, hypertensive, admitted to the medical ward for a workup of PUO. Appetite is mildly reduced. A random blood sugar is 150. So the lab one. So what will you do is the first question. So 150. HbA, would you do an HbA1c? Would you do blood glucose monitoring? Would you start the treatment for hyperglycemia with this one value? Would you do the first two, which is HbA1c, and then initiating blood glucose monitoring? Or would you just pass this off as normal, and you're not really bothered about this value? So what's your take on this? B alone or 4? Okay, fine. Yeah, I think everybody has the answer. Everybody knows this. So that is both A and B is what we would like to do. Yeah, fine. That is fairly straightforward, because you want to know whether this patient has pre-existing diabetes, and HbA1c helps in that scenario. There are caveats to that. We'll come to that later. But you also want to know how the blood glucose is behaving during this inpatient admission of the patient. So this is what we have. So the patient has an HbA1c of 7.5, and the 24 hours blood glucose values by glucometer, okay, the other one was a lab value, but glucometer values are 160, 200, 220, and 240. Out of this, I think the after dinner one is 240. That's a post-prandial. All the others are before meals. So that's what you're seeing here. So how will you manage this patient? What do you want? Do you want to start an oral agent? Do you want to start a sliding scale? Do you want to start a basal bolus regime? Would you go for a premix, or you would start a basal insulin alone? I think everybody would go for a basal bolus, isn't it? And I think that's kind of what we would do. Okay, so I think we will discuss that in detail. So this is It's fairly straightforward, very simple, straightforward case. But let us look at all the aspects of that case. So when it comes to an inpatient hyperglycemia management, there are three things that are three most important questions are, what is this a new onset hyperglycemia, or is this pre-existing diabetes? And I think that is an important question to answer. And then the second one is, how do you diagnose the new onset hyperglycemia and diabetes in a hospital setting? I think that we have touched upon that in that the HbA1c thing. We'll come to that later. And then how do we manage this patient in hospital? So this is a slide which many of you would have seen umpteen times. It's a study that was done nearly 18 years ago. An interesting study, because although it is a fairly small study, what it showed was that if you look at patients admitted to hospital, nearly 26% have diabetes. This is a study from that time ago, but I think it probably is the same, or maybe it would have increased now. So one half of patients who are admitted to hospital have pre-existing diabetes, depending on what sort of hospital and setting, but this is an acute admissions ward. That's where the study was done. Now 12% had new hyperglycemia. Okay, you could call it stress hyperglycemia or new onset hyperglycemia. And the rest were normal. So this is interesting. And what we have is some data from India. This is the only data that we could find. There again, the figures are somewhere around that. So about 17% of patients admitted to Medanta over that 2015 had a known history of diabetes. There was no mention of the stress hyperglycemia. Now, what is the importance of this? The importance is that what has been shown in this study, I haven't put a slide on this, is that interestingly, the stress hyperglycemia patients had an increased mortality. Again, something which we will discuss again in the later sessions. Why would that be? It is quite possible that stress hyperglycemia as an entity shows that these patients are sicker. That's probably the reason. So when a patient presents to you in a acute setting, to our medical admissions, if they have stress hyperglycemia, that's a scenario which needs to be taken as kind of, you need to take note of it. It's not something which we should brush aside saying that, oh, this patient doesn't have diabetes, I'm not bothered. Actually, the in-hospital mortality of these patients is higher than even patients with diabetes, suggesting that this could be used perhaps as a marker for severity of their medical illness. So stress hyperglycemia is something which we should take note of. Now, how do you diagnose this? So those are the kind of values that you want. So any hospital hyperglycemia of more than 140, in our case it was 150, so that's why we took that as important and did the follow-up tests. The stress hyperglycemia is defined as a blood sugar elevation of 140 or more than 140 in a hospitalized patient. However, there is no history of diabetes and there is no HbA1c elevation. That means HbA1c is less than 6.5. So there is, you don't have a previous diagnosis of diabetes, and there is no evidence of diabetes as things stand. That is what is defined as stress hyperglycemia. A value of more than 6.5 found out at that time without a history of diabetes would mean that it's a new onset diabetes, or you have just diagnosed that type 2 diabetes or type 1, most likely type 2 in this scenario. The hypoglycemia is defined as a value less than 70. So these are the kind of figures that have been accepted worldwide. And the severe hypoglycemia is a blood glucose of less than 40. So what do you do when you see patients with, or when patients come to a hospital setting? I think the important thing is that upon admission, all patients, you should get two things. One is history of diabetes, absolutely important, okay? And obtain a lab blood glucose, okay? Not just a glucometer one, but a lab blood glucose. So the first blood sample that goes in the patient, it's best that you always I'm sure all emergency unit protocols would have that. Because that then sets the ball rolling. If you find that there is no history of diabetes and the blood glucose is less than 140, many times you don't necessarily need to monitor the blood sugars in that patient. However, you might decide to check the blood sugars, the point of care testing of blood sugars, in given scenarios, and that might be depending on the patient's clinical status. As we said, patients on steroids or enteral feeding or any other aspects, you might want to have regular. So that is to the discretion of the physician who is treating that patient. You find that the blood sugars are more than 140, there is no history of diabetes. Those patients need blood sugar to be monitored, okay, which is what, that patient had raised HbA1c as well, but even if this HbA1c is less than 6.5 in our case, if the blood sugar was raised, we need to start monitoring at least for the next 24 to 48 hours to see what's happening. And if the blood sugars are remaining high, that is when you would decide on treatment, whether you want to. Whereas if your HbA1c is more than 6.5, then or history of diabetes, then you certainly need to continue monitoring and you need to initiate the treatment accordingly. Okay. So I think that kind of gives you a fairly simple way of looking at how to manage patients who are coming into hospital, or how to recognize and diagnose diabetes, not manage, but we'll come to that. So what is the use of HbA1c in hospital patients? More than 6.5 gives us a fairly clear-cut diagnosis. I think that's probably where it is very useful. 5.7 to 6.4, risk of diabetes. So clearly these patients, if they are put through a stress, they probably will become hyperglycemic. It might revert later, but then depends on the clinical status and clinical scenario. Now, so where it becomes useful is, one, to assess the glycemic control prior to admission. Did they have diabetes even before, which was undiagnosed? To assist with the differentiation of newly diagnosed from stress, as I have already told. Is it stress hyperglycemia? Is it pre-existing type 2 diabetes? And it's also useful to decide on an optimal treatment at the time of discharge, because if it's stress hyperglycemia, most often you would be stopping treatment, or you might, it's going to be for a short term in most patients again. Whereas if it's type 2, established type 2 with a raised HbA1c, you will at least have to look at, if not insulin, you will have to look at a different treatment at the time of discharge. Now, there are caveats to the HbA1c, and we should keep that in mind. Just not take that as a 100% test which will give you the answer. I'm sure none of us do that. However, it is a very useful test, but we should always interpret that with caution in these sort of scenarios. So there can be odd patients who have got hemoglobinopathies. High-dose salicylates can interfere with that. Hemodialysis patients, again, it's not really interpretable. Anemia of different types, transfusion, all gives falsely low HbA1cs. So you should, again, also make sure that it is a standardized test that is being done by your lab. Now, the third aspect of the talk, which is how should we manage hyperglycemia in a non-ICU setting? Okay, so we have recognized it. We have said that it's either stress or type 2, newly diagnosed or pre-existing. Now, how do you treat this? For that, the glycemic targets are again now well accepted and pretty much followed everywhere. And I think that is something to take note of. So you want to maintain the fasting and preprandial blood glucose of less than 140, and you want to maintain the random less than 180. You would modify the treatment if the blood glucose is less than 100, and that is to avoid hypoglycemia, because these patients in hospital can have erratic eating habits. They might have different tests, they might have different medications. So all these can interfere with the blood sugars. So you really want to make sure that you don't drive the blood sugars down too much, because the biggest risk for patients in hospital as an acute thing would be a hypoglycemia, and you always want to avoid that. Now, there might be patients, so 140 to 180 is what we want to keep the sugars at. There might be an outpatient where you want to go for a tighter control. It's entirely to the discretion of the team to do that. And there might be less stringent targets for terminally ill patients, and that's again perfectly acceptable. Most of the guidelines have recognized that and would want you to do that as well, that we don't try and go for very tight controls in sick patients, in very sick patients who have limited survival. So what are the factors that would decide treatment of hyperglycemia in hospitalized patients? The most important thing is the type of diabetes, and is it type 1? Of course, your treatment is, you know how to treat type 1. Type 2, you are a little bit more relaxed, but still you would want those targets to be achieved. So that is an important aspect. Patient's current blood glucose concentration, the prior treatment, the severity of the illness, and the expected calorie intake. I think a nutritional assessment of these patients is perhaps one of the things which many of us, or not individually, but many of the hospitals don't do very well at. A nutritional assessment of these patients is poor in our setup. And I think that is a very important aspect, because when you're trying to manage diabetes, if you don't know how the patient's food intake is, what kind of this thing is, you're never going to manage it properly. So I think it's a very, very important aspect that we shouldn't forget. Monitoring, you would start off with the pre-meal glucose levels and at bedtime. So the 4 times would be the best to start off with. So you then try and adjust that and then move on. Then the 4 to 6 hour monitoring in patients who are on enteral feeding. What treatment would you want? You would generally look at insulin. In fact, for almost all patients, you would have insulin. Generally, you don't recommend oral hypoglycemic agents in a hospitalized patient. That is because they will be again going through different tests, that the tablets have their own side effects, and it's very difficult sometimes to control those in an acute setting with tablets. And there might be an outpatient who needs, or other patients, or sicker patients who will need continuous IV infusion. But again, the only important point there for me to mention is that try and avoid IV insulin infusion in general wards. And I think that they can be dangerous. Even if we have the best team, they are not going to sit with these patients. Nurses are always stretched on general wards. IV insulin infusion, as a rule, is avoided in general wards if that's possible. The tablets, again, as you know, most of these tablets have their own issues in a hospital setting. The hypoglycemia is the biggest problem with sulfonylurea. Metformin, again, you know this. We will again discuss all this later. Glitazones, which cause fluid retention. The DPP-4 is an interesting scenario. There are now studies looking at DPP-4 inhibitors, which could be used even in an acute setting. Okay, even in a hospital setting, they are one of the agents that are thought to be fairly okay, other than insulin. I think we need more evidence before we can use that, or we can recommend that it's used. But there are studies which have looked at sitagliptin and other gliptins in this scenario in hospital settings. If it's mild hyperglycemia, there might be agents which are useful, which don't cause hypos. SGLT2 inhibitors, as a rule, please discontinue them in hospital patients for obvious reasons that you know of, the ketoacidosis and all the electrical imbalances and all that. In acute setting, this is important. I mean, we are not fearful of that in a stable patient, but in acute setting, this is important. So the long and short of it is, insulin therapy is the preferred approach. Which insulin therapy? The 3, again, all these will be discussed further. So I don't think, is time an issue, Veda, or can I just take 5 more minutes? Okay, fine. So that's okay, is it? Because I think being interactive, I thought we'll just complete this and move on. Okay. So the 3 insulin or types that we would use is the sliding scale, which has been a favorite of many, especially non-medics, I would say. I wouldn't say non-medics, non-physicians. Surgeons like it, some anesthetists like it. But I think people have now moved away from it to a large extent. Large hospitals definitely discourage that. The basal bolus is the one we should be using, so there will be a long-acting and rapid-acting with the meals. The pre-mixed, perhaps not again great. So the preferred is basal bolus. Now, the sliding scale, this is what a sliding scale is, isn't it? You all know. So basically, it is easy for the resident, you write this and go, and if the nurse calls, you say, I've written the sliding scale, you just look at it and give it. So if the sugars are 200, you give 3, no, sorry, yeah, whatever, 250, you give 4. However, this is not the right approach. We all know that. Why is it? Because this is a reactive approach. This happens after the sugars have gone up. So you try and, it's now recommended that we shouldn't be doing this, and there are even studies to support this. I'll just quickly go through that. So the advantages of a sliding scale is that it's very convenient, it is written, simple, and nurse can just follow it, that's it. However, the problem is, you're always managing the sugars after it has gone up. So it's a reactive approach. And the issue might be the roller coaster kind of effect. So you have a sugar that's high, the next one you give an insulin is low, and then again the next one is, then you don't give anything, then the next time it goes up, again you give it, so you go up and down, up and down. So that's really not the way to manage diabetes, isn't it? We know that. So this is what happens, the roller coaster kind of effect of insulin sliding scale. However, what you want is a physiological insulin, which will deal with the physiological issue. So once you find the profile of these patients, you want to give, so postprandially is when the sugars are going to go up. So you need insulin to cover that postprandial one. So a pre-meal insulin, you want a fixed dose which can be adjusted. That's what you want. You don't want to be giving just when the sugars are up. This is one of those studies which looked at the basal bolus versus the sliding scale, the Rabbit-2 trial, and they showed that the sliding scale had higher levels, or the basal bolus gave you better control with less of hypos, okay? Now, what are the subcutaneous insulin options? You have the basal insulins. You can either use the human insulin, the NPH, which is good enough in most settings because it can be given BD. In those settings, it's usually that is better. Glargine or Detamir you can use. Degludec, much more long-acting. May not be a big advantage in a hospitalized patient because by the time it reaches a steady state, your patient might be almost ready to go out of hospital. So many times you prefer NPH or the kind of medium-acting basal insulins. The nutritional insulin is the one that you would give along with the meals, and then the correctional insulin, which would be the insulin that you would give over and above, it's the short-acting insulin, which you give over and above the nutritional insulin that you're giving. So that is kind of what you should do. And you correct the pre-meal glucose excursions, and you adjust adjust all these doses. So you have flexibility there. You have 2 basals, which will give you a better basal control through the day as well as through the night, and you have the prandial insulins, which will give you control when the patient is eating or not. And in this, just a word of this thing is that perhaps using an analog insulin is good. It's not necessary that you should use it, but the advantage there is that you don't necessarily need to wait after injecting. In fact, you can even give the analog insulin, analog short-acting insulins. You can even give the insulins soon after the patient has eaten. Big advantage in patients who have erratic habits of eating. They may not want to eat the hospital food. Who wants to eat hospital food? None of us do. So it's easy to adjust the dose. Whereas if you have given a certain dose, then you're stuck with those patients. You will have to then give, dextrose and all that. So it might be an advantage in those patients. And again, the nurses can just give the injection and give the food. They don't have to ask the patient to wait for half an hour because they might get stuck with other things. So this is what you would do. So type 1, you would reduce the dose. So the basal bolus is kind of established, and you give in type 1, in insulin-treated type 2, and in sustained new onset hyperglycemia. You might want to reduce the dose, pre-existing dose to start with, and then increase it. In type 2, who have been on OHAs, again, you would go for a basal bolus regime, and you would adjust the dose. You would stop the tablets to start with. You don't really want to continue any of the tablets if that's possible. So I think our case, we have all agreed that what we want to do is this. We want to do an HbA1c, a blood glucose monitoring, and we have started the basal bolus regime. I think we had, even before the talk, we had decided that. So all that I had done was drive home those points. So you have put a correctional insulin as well in the chart. You can see that there. That is something which we standard would put. So if the sugars are low, you would reduce the insulin dose. If the sugars are higher, you would add on top of that. So this is a correctional insulin over and above the prandial insulin they are getting. Okay, so again, I'll just show you in that example. So basically, for the first day, you have written the sugar, the insulin regime as if it's Apidra 664 and Glargine 16. So you have put the basal bolus, and you find that this is these are the values 180, 250, 160, 180. So with the 250 before lunch is the only one that is raised. So you've given a correctional insulin there. That is based on that correctional insulin that you have written up. So you have added +4 onto that, and you have given it. Next day, you have again given the same dose. You might actually query that. Should we have increased that before breakfast glulysin? Perhaps we should have. Because if you look at it again, the pre-lunch is high on day 2. Okay, so that's perhaps where you could have made that change on second day. You might sometimes wait also, because these patients have come in, you're not sure about what is happening. On day 3, you have, so that insulin dose has been increased, okay, by 2 units based on what happened on day 2. And by day 3, you have got the perfect kind of control that you want, which is 130, 180, 150, 180, as you can see. So perfect control you have got. So this is what you can achieve by having this sort of insulin regime, which is a basal insulin, prandial insulin plus the correctional insulin. So to summarize my talk, sorry that I have superseded my time significantly, but I've kind of said that we need to assess all patients for a history of diabetes. You need to do an HbA1c test. You need to look at a lab blood glucose. Very, very important point, a lab blood glucose, not just a glucometer one to start with. And then you would initiate point of care testing. You want a level of between 140 and 180. And the insulin, the preferred insulin regime in these patients, in a patient who comes into hospital, is a subcutaneous basal bolus kind of regime to which a correctional insulin is added. Try and dissuade your colleagues from using sliding scale. Thank you.